For a direct anterior approach, truly speaking, can we do it in majority of the patients? The answer is yes.
Achha.
But it needs a lot of expertise. We have done more than around 350 hip replacements with direct anterior approach in the last 1 year or so. When you hear robotic, people have something in mind that a humanoid robot is actually going to come to the theater. They have that sci-fi movie Hollywood
Yes.
in their mind that there
Yes.
will be a robot who is actually coming there.
What age is considered too old for hip replacement?
None.
None. So what's the
Highest
old
age at
age
which we have
restriction?
done a hip replacement is 108 years.
108 years. And the youngest one?
16.
What's most common misconception patients have about hip replacement?
That the patients are not able to going to be able to squat or sit cross-legged is the commonest misconception.
Today, we are talking about a game-changing technique in hip replacement surgery, the direct anterior approach, or DAA. The approach is known for being muscle sparing, allowing patients to recover faster with a less pain. We will uncover how it differs from traditional method and why more surgeons are adopting it. From robotic assistance to advanced pre-operative planning, precision has never been better. We will also discuss who makes the best candidates for this procedure. Common concerns like dislocation and leg length discrepancies will be addressed head on. Plus, we will separate fact from fiction in our Mythbuster and rapid fire segments. So, if you are curious about how technology is redefining hip replacement outcomes, you are at the right place. Let's get started. Joining us today is Dr. Abhijit Agashe, a distinguished orthopedic surgeon renowned for his excellence in joint replacement arthroscopy, sports surgery, and trauma care. A pioneer in his field, he has performed Maharashtra's first ankle replacement in 2012 and his town's first direct anterior robotic hip replacement in 2023. Trained under global masters in South Korea, Germany, and Switzerland, he blends innovation with precision and compassion. Dr. Agashe's unwavering dedication to restoring mobility and transforming lives has earned him immense respect and admiration. Let's welcome Dr. Abhijit Agashe. Hello and welcome to Sahyadri Health Talks. I'm Dr. Tushita, and today we have with us Dr. Abhijit Agashe. Hello,
Hi.
sir. How are you?
Hi, Tushita. Thank you so much for inviting me for the Sahyadri Health Talk.
Thank you, sir, and thanks for giving us this time today.
Sure.
So today we are going to talk a lot about hip replacement and specifically direct anterior approach in hip replacement.
Correct.
But before I jump in there, 4,000 almost a ballpark number of joint replacement surgery. How has this journey been, sir?
It's been a nice journey since 2005. I am into joint replacements and in Sahyadri since 2006. Um, we have been treating really challenging cases, and in the recent times, we have seen a sudden surge in the number of hip patients. And with direct anterior approach, yes, we are able to give a fantastic result to the patients. As we keep on discussing it further, we will understand it. But overall, in the last 20 years, it's been a fantastic journey.
So how does it feel now that when the patient walks into your OPD and the diagnosis is that the patient needs a hip replacement? So how is the feeling? I mean, do you still get those butterflies in your stomach like the first case which you did?
Definitely not, but yes, every case is a different case. So no two patients are the same. So there will be some different challenges for every person. And yes, as a surgeon, I would be really interested in doing something new or something where there's some challenge to the surgery. So otherwise, it's quite routine to do a joint replacement nowadays. And truly speaking, the questions that I used to get in 2005 compared to the questions that I get in my OPD now, I have changed dramatically.
Mm-hmm.
Now patients are much more aware of the surgery. They are not naive about surgery, what is going to be done, or all those things. They are mainly focused on technology. What are you going to do? What is the philosophy behind a particular surgery, or
Mm-hmm.
maybe what implant you are going to use? what approach are you going to take, are the questions that we see nowadays increased compared to what I started way back in 2005.
While we talk about increased awareness among people who are potential who have the potential requirement of getting a hip replacement done, does it annoy you at times when people come and give you over information about it?
Many times I do. Particularly there are a few implants where it's called as a dual mobility implant, where patients keep on asking you about that particular implant, whereas it is actually a reserved implant not to be used in younger age patients.
Mm-hmm.
But for the want of better range of movement and to prevent dislocations, there are a few misinformation circulating all over the media that this particular implant leads to better results.
Mm-hmm.
But I would like to in the beginning tell everyone that yes, this is a good implant for the elderlies and not for the young.
Young
So
ones.
that's the question which keeps on annoying me. And the second question which annoys me is the patient already has a stage 4 arthritis of the hip or the knee, and the patient is not willing for a surgery and is asking for something which is not possible.
Uh-huh.
So they want to get back to their normal routine without
Mm-hmm.
a surgical intervention. Yes, that is possible if you come at the early phase when your joint is still not really very bad, where we can probably repair your joint and get you
Correct.
back to a much better level.
Yeah.
But these two questions really still annoy me when I am in the OPD and the patients keep on asking you the same thing one
Yeah.
over and over again.
So you have been practicing across the globe, if I'm not wrong, be it Pune, Mumbai, or maybe overseas like African countries.
Yeah.
So what's that one thing which you see across the globe, which is common in all the patients?
Obviously, the first and the foremost common thing is everyone wants to avoid a surgery. Even if I am going to go under knife, I would try and get all the possible options checked out before I actually go in for surgery, which is very common in our country.
Uh-huh.
Comparatively, what I saw in African countries is comparatively their acceptance for surgery is much faster.
Acha.
They understand that yes, this is the only option, and probably it is also because of finance. They do get some financial help from the institutions around. There will be some government financing funding for these surgeries.
Mm-hmm.
So probably their acceptance compared to our country is much better.
Mm-hmm.
I was there in the US or in the Germany, and one very weird thing that I found out was when I was studying there, my professor under whom I was studying
Mm-hmm.
was keen on postponing the surgery, and the patients were used to beg him that no, no, get it done
Mm-hmm.
early so that I go back to my sporting activities.
Acha.
Now, that is something which is not seen in our country over the last, I think, almost 15 years, and that's a welcome change that I have seen in our country for the last 5 years.
Okay.
Yes, we are getting a lot of younger patients with arthritis, and they do not wish to change their lifestyles. They want to go and play sports, they want to go and play golf, maybe cricket, maybe
Mm-hmm.
some low impact activities, and their arthritis is not allowing them to do that, and they are okay to go ahead and do surgery early.
Mm-hmm.
And mind you, if you do that surgery at that point of time, the
Mm-hmm.
results are unmatched.
Okay.
If you are arthritic for a pretty long time and your joint, not only the joint, but your muscles are worn out, it is going to take a long time for you to recover. If
Mm-hmm.
you do it early, the results are phenomenal.
Mm-hmm.
And I am seeing that change in our country over the last 5 years, which I saw around 20 years back when I was
Mm-hmm.
in Germany studying doing my fellowship,
Mm-hmm.
or when I was in Korea and doing my fellowship in joint replacements and revisions. So that mentality has started coming up in our country also in the recent past, maybe in the last 2 or 5 years maximum.
Mm-hmm. So while I was in conversation with you, discussing that what should be today's topic and how do we go about it, and we came up with this idea that we will do hip replacement and the topic today. I remember you spoke that there has been a surge in the cases post COVID,
Correct.
that people are reporting more with hip issues, I would say. So post COVID, there has been a surge in hip issues in patients.
Absolutely.
Why so, and why are we seeing this trend?
See, primarily we need to understand why does you get or why anyone gets a hip problem.
Hmm.
So the first and the foremost important part is an arthritis. So arthritis of the hip in our country, fortunately, is much lesser compared to the Western world.
Hmm.
It could be because of our daily habits of sitting cross-legged or maybe daily habit of squatting,
Mm-hmm.
which is relieving arthritic changes in your hip and increasing your arthritic changes in the knee.
Hmm.
But primarily hip arthritis was much lesser compared to Western world. Post covid we have seen a sudden rise, and this sudden rise is not just because of arthritis, but it is because of something called as an avascular necrosis.
Acha.
Now this is not a new disease. The avascular necrosis was still there before covid.
Mm-hmm.
Only the patients who had undergone some surgery for the hip for fractures, or those patients who were alcoholics, or those patients who required steroids for some other health conditions,
Hmm.
were going and developing hip arthritis because of AVN. Now in COVID, what we have seen is a lot of patients. I have operated almost maybe 4 or 5 cases in a week.
Mm-hmm.
Majority of them now are COVID and young patients. They do tell me the history of a COVID infection,
Acha.
but they were treated at home quarantine. So they were probably
Okay.
given just a blood thinner
Mm-hmm.
and nothing else. So it is not the steroids that were given to the patients, not the other medications which were used for COVID, but
Mm-hmm.
it is the COVID disease itself. So COVID, what it does is it leads to an coagulation abnormality. That
Acha.
means your blood clots much faster compared to the others.
Okay.
And in the hip, if you see the ball of the hip, the ball and socket joint of the hip, the
Hmm.
ball has a blood supply only from one side.
Acha.
And when you get something similar, we called it as an end artery. So
Acha.
which means you do not have a collateral. There
Mm-hmm.
is no other artery which supplies blood to that particular part of your body,
Mm-hmm.
and these end arteries lead to clogging because of covid, because of increased coagulation abnormality,
Uh-huh.
which leads to a sudden infarct, or what you see in heart. So you get a heart attack.
Yes.
So you see in the brain that you get a stroke.
Stroke.
So it is very similar. You get a stroke to your hip, you get
Uh-huh.
a sudden collapse of your hip blood supply,
Acha.
and the minute that blood supply is cut off, that area is going to die. Since there is no collateral, there is no way how that area is going to get blood from anywhere else.
Mm-hmm.
That head keeps on getting bad and bad
Necrosed
and
and.
necrotic, and over a period of time will develop arthritis, and the patient will need a hip replacement.
Mm-hmm.
So that's the pathophysiology, what we say. That's the pathophysiology how COVID has definitely increased the number of hip problems in our patients. We do see a few patients who have got avian of the shoulder,
Acha.
but since shoulder is not a weight bearing joint, you do
Hmm.
not put weight on that
Yeah, yeah,
bone,
yeah.
the patients are not that painful.
Hmm.
Hip is one structure where you have to have full weight bearing on that,
Mm-hmm.
particularly in a stance phase.
Mm-hmm.
So hip problems have definitely surged post COVID.
So, are we saying that those individuals who suffered from COVID are at a greater risk of having hip issues in future?
Unfortunately, yes.
Okay.
So, truly speaking, there are no studies which say who are the patients who are
Mm-hmm.
going to get it,
Mm-hmm.
because I have seen so many patients who have got COVID. Everyone in my family has suffered COVID,
Hmm.
or almost everybody I know has
Hmm.
suffered COVID sometime or the other in the three waves.
Hmm.
Fortunately, unfortunately, none of them have it.
Acha.
So, who is the candidate who is going to get it? I don't know, truly speaking. But yes, the candidates who have undergone COVID,
Mm-hmm.
those who were really serious in COVID, had a
Mm-hmm.
very bad chest score, who
Mm-hmm.
were admitted, given a very high dose of steroid,
Mm-hmm.
they have developed avian, which is understandable. But
Mm-hmm.
those patients who were home quarantined, who
Mm-hmm.
did not have a severe disease,
Mm-hmm.
they have also got very bad arthritis of the hip due to COVID.
Okay.
See, a lot of patients ask me in the OPD that is it because of my injections which were given
Hmm.
during my COVID time?
Yeah.
I tell them very simple: a alive person will have an arthritis, a dead person will not. So whatever was done at that point of time was to save your life. So don't try and blame it to the surgeon or to the doctor
To
who has
the.
saved your life in that particular
Yeah.
phase. It is because of that treatment you have come to me for hip replacement.
Mm-hmm.
So it was mandatory, it was something
It
that
was
was
required
new.
that point of
Correct.
time.
And none of us knew what this disease is,
Yeah.
none of us knew what the treatment is. So whatever was done was probably the correct thing to do. And fortunately, now we have got vaccines, and hopefully in the next 1 century we should not be getting a similar disease. If you look at the history, that is what the history says, that every
Yes.
100 years we get some pandemic like
Pandemic.
this.
Yes.
So yes, COVID is increasing the possibilities of hip replacement, and there is a sudden surge. There is a plethora of patients who are coming with hip disease in particular post COVID.
Mm-hmm, mm-hmm. So when we talk about hip replacement, there is a lot of apprehension in people's mind. Uh, while we understand, as you said, that hip is one of the major weight bearing joints of the body,
Correct.
and has is quite complex on its own. But why this particular fear of hip replacement in people? Do you have you always seen that in patients?
Absolutely, absolutely. Let me tell you something that, as I said, hip replacement in our country maybe 5 years before
Hmm.
was not so much. The requirement was not so much.
Acha.
Any replacement, truly speaking, is meant for a person who is elderly, preferably 65 and above.
Acha.
So, a few restrictions on their daily activities like sitting cross legged or maybe squatting or sporting activity, they are absolutely ready to accept it because they had in mind that, okay, I'm already 65, 70, and if I'm not able to do these things, I'm okay with that.
Hmm.
Post COVID, there is a sudden rise in the hip problems, and
Problems.
majority of them are young.
Acha.
So, if a young person is, supposing if one of your family member who is around 30
Hmm.
and needs a hip replacement, and he comes to me and I tell him that, boss, after a hip replacement, you are never going to be able to sit cross-legged. You will never be able to go sit down on the floor, never be able to go and participate in a sporting activity, not even for recreation, leave
Mm-hmm.
alone the professional sports.
Mm-hmm.
You will never be able to squat. Then these patients are scared, and
Yeah.
which is correct. So this is something new, that a young arthritic population who is needing a replacement, and then we are inducing a lot of restrictions on their
Post
activities, and that's why they are
surgery.
scared about a joint replacement, which is absolutely understandable.
Mhm. So, as we speak about direct anterior approach on in hip replacement, help us understand how is this different from the traditional hip replacement?
Yeah. So if you see, traditionally we have been trained on something called as an posterolateral approach.
Acha.
Posterolateral approach is the approach which is taken from the back side of your hip.
Acha.
So the incision is primarily half on your buttock and half on your thigh,
Acha.
and from there you go inside to the hip.
Mm-hmm.
When you are going inside to the hip, you have to come across so many important structures which you need to cut. Obviously you will repair them after surgery,
Mm-hmm.
but primarily you need to cut them to approach the hip and open the hip,
Mm-hmm.
and then replace the hip in the correct position. So direct anterior approach is something which is completely a 360-degree reverse of that.
Acha.
Instead of going from the back side, you
Mm-hmm.
go from the front side of the hip.
Okay.
Number one.
Mm-hmm.
Number two, you do not have to cut anything when you're reaching the hip.
So
You go,
minimal,
it's a minimally invasive surgery,
invasive.
but more importantly, it goes between the muscles.
Acha.
There is no nerve which is at jeopardy when you're actually going to approach the hip.
Okay.
Second, the patient is lying supine. Supine means is flat on
Flat
his
on his
back.
back.
So the patient is also more comfortable.
Hmm.
A lot of patients who have hip arthritis also have some problem of the shoulder.
Acha.
When I'm putting the patient on the side, the patient is anesthetized below navel level, so he
Mm-hmm.
doesn't feel anything there.
Mm-hmm.
But when he's lying down on a side
The
for say around
shoulder.
2 hours, he starts getting that shoulder pain.
Correct.
So the minute the patient is flat, they are much more comfortable.
Comfortable.
Yes, it's a different approach. It needs a lot of training. It is something that is not very commonly done till now, but it's a fantastic approach, and with that you
It's
can.
also called as a muscle sparing technique.
Correct, correct. So, as you said, it's a muscle sparing technique. As I was explaining in the posterior approach, what
Ah.
you do is you cut the muscles to reach the hip.
Hmm.
Here, you enter between the two muscles. The two muscles are rectus femoris is one muscle which is on the front side, or sartorius with that,
Mm-hmm.
and TFL is the second muscle which is on the other side. So you develop. See, there is a gap in the two muscles in natural course.
Mm-hmm.
So you just develop that gap and enlarge it to see your hip.
So
Now
basically, don't disturb the
you don't
muscles.
disturb the muscles at all, you just retract them, you take them to a side and you approach the hip.
So, in terms of recovery, or from the patient's perspective, how is it more beneficial? One thing you told is, of course, the supine position is more comfortable for the patient
Correct,
because most of these patients are just anesthetized below the hip area.
correct, correct.
So that is one part of it. What are the other benefits of this direct anterior approach?
See, as we were talking, it's an intermuscular approach,
Hmm.
so there is no muscle which is going to be disturbed. You
Hmm.
just have to push a muscle aside.
Mm-hmm.
So the recovery part, since the muscles are not damaged at all, is very, very, very fast. Second, it is not only just an intermuscular approach, it is also internervous approach. What do you
Acha.
mean by an internervous approach? is the muscles on the inner side of your incision are given a nerve supply by a different muscle, whereas the muscles on the outer side are given a nerve supply by a different nerve.
Acha.
So the two nerves are completely separate, so there is no way in which how you are going to stretch that nerve.
Hmm.
So the pain post operatively is much lesser.
Mm-hmm.
The patient walks independently really very fast.
Mm-hmm.
We allow the patient to walk if we are doing unilateral, that means just one hip
One hip.
on the day. We allow the patient to walk the same day evening. We allow the
Okay.
patient to walk with a single cane the next day.
Acha.
The patient goes home on the second day,
Oh.
and maybe in a week's time the patient is walking without any walking aid, which was not heard of with the previous posterior approach. The patient can lie down on a side on the same day of surgery, and within 3 weeks I allow those patients to sit cross-legged on the floor,
Oh,
which
wow.
we were not doing with the posterior approach even
Yeah.
after 2 years. So there is definitely a faster recovery. The pain is much lesser
Much
with the
lesser.
direct anterior approach.
So, when we talk about direct interior approach, pain and recovery is one part of it. The other thing which we also understand is all these procedures are robotic assisted,
Correct.
right? So, does this direct interior approach with robotic assisted, technique, how is it beneficial to you as a surgeon?
See, for the first time, let me make it clarify to the viewers. When you hear robotics, people have something in mind that a humanoid robot is actually
Yeah.
going to come to the theater.
Yeah.
They have that sci-fi movie Hollywood
Yes.
in their mind that there will
Yes.
be a robot who is actually coming there.
True.
So it's not something like that.
Yeah.
These are two eyes of the robot and some machines in our hand.
Hmm.
So the robot gives me a guideline. Where should I do my surgery? What is the sizing?
Mm-hmm.
What are the correct positions of my implants?
Hmm.
Ultimate decision is always with the surgeon. The
Yes.
robo guides you. If I start going wrong, the robo shows me on the screen that uh, increase by half a millimeter, the robo screen starts turning red.
Hmm.
So precision is something that the robo is going to add. Sizing is something that the robo is going to add, and that makes the surgery even more safer and even more precise. So yes, has the robotic added to the value of hip replacement, particularly direct anterior? The answer is 100% yes.
Hmm.
It has definitely added a cutting edge over the previous techniques
Mm-hmm.
in terms of precision, in
Hmm.
terms of perfect placement of the implants,
Hmm.
and in terms of sizing of the implants.
So, what role does a preoperative imaging, and coming to the diagnostic part, which I should have covered before? So, what role does a preoperative imaging and diagnosis plays
Yeah.
in hip replacement?
So pre-operative diagnostic, there are two ways in how you do it depending on the technology that you have. There is one technology called as image based robotic technology, and the other one is called as an imageless robotic technology. So when you talk about image based technology, you need to get a CT scan of the patient pre-operatively and then feed that CT scan to the patient.
Acha.
What that adds to is the machine already knows the bone structure, but that also adds to a lot of radiation to the patient, which is not a very good idea. As you know, that any X-ray radiation is not good for the body.
Hmm.
Now here we are doing the CT scan of the hip, so you are doing the CT scan of an area of your genitals and the reproducing organs, so which is not a very good idea, truly speaking.
Yeah.
So a image less robotic is
Mm-hmm.
something where you will not need a CT scan, but
Acha.
you will need a few X-rays.
Acha.
So these X-rays are primarily of the spine,
Hmm.
where you take a X-ray in standing position and
Hmm.
in sitting position, plus the X-ray of your hip,
Hmm.
and then there are a few calculations done on the X-ray by the surgeon,
Mm-hmm.
and those numbers you can feed it to the robo so
Acha.
that the robo knows what is the deformity that you are dealing with.
Mm-hmm.
And then these numbers, when you feed it to the robo will calculate intraoperatively the position of your hip, the new hip that you are going to put in.
Acha. Okay.
So image less robo is safer.
Hmm.
Image based robo might give you a cutting edge over the image less in terms of getting the real time data from a CT scan.
Okay. So, are there any particular anatomical features or consideration, or maybe some particular patient profiles, I would say, which are very apt to go for a
For a
direct
direct
anterior
anterior.
approach?
So For a direct anterior approach, truly speaking, can we do it in majority of the patients? The answer is yes,
Acha.
but it needs a lot of expertise. We have done more than around 350 hip replacements with direct anterior approach in the last 1 year or so
Wow.
with robotics.
Wow.
And in our initial 50 cases, we were very skeptical when we are choosing the patients. We need to have something called as an valgus angle at the neck.
Acha.
The patient has to be a very thin built patient.
Mm-hmm.
With time, we have increased our indications to a varus neck, to a heavy patient, to a obese patient. But still, there will be a few exclusions in direct anterior approach, like patients who have undergone a hip surgery previously with some previous incision.
Acha.
So, if the patient has gone undergone a surgery with a posterior approach, it is not a wise idea to go by anterior now.
Anterior approach.
If the patient has a previous history of trauma and there is a lot of other surgeries done around the hip, not a replacement but for fixation of the fracture, still that is not a good idea. And the most important is a muscular patient. See, it's an intermuscular approach where I'm not going to cut any of your muscles. If I'm going to deal with a patient who is really really very muscular hefty,
Mm-hmm.
I have to push that muscle or pull that muscle too hard. And then, if I am pulling it too hard, there is a higher chance of injury to the muscle. So, those patients who are really very muscular are still a contraindication or a reservation where I would not be doing a direct anterior approach. But rest, other than that, majority of the hips can be done by a direct anterior approach. Yes, there is one more contraindication, and that is called as developmental dysplasia of the hip.
Acha.
And that too in crow type 4, where the hip has migrated way too above the normal level. And then getting it back, I need to cut muscle so that my hip comes down.
Yeah.
With a direct anterior approach, I am not going to cut any muscle, so the hip doesn't come back. And then doing it without cutting the muscle and getting the hip into its normal position is impossible. So, for a high dislocator, for a very muscular patient, direct anterior is not the approach. Leave alone these two indications, every patient is a candidate for a direct anterior approach without any doubt.
So, the typical most common complication or post-surgery complaint, post a hip replacement, are two things which I have heard. One is dislocation, of course.
Correct,
The other one is the leg length discrepancy.
correct.
And direct anterior approach has been a boon when it comes to these two, right?
Absolutely.
Help us understand those two.
See, there are two issues after hip replacement that everyone is scared about. First is dislocation. The second one is limb length discrepancy. In majority of the times, the operated leg is going to be longer
Longer
compared to
than
the other
the
side.
other one, yeah.
Why does it occur? First, dislocation is because I am cutting your muscles, number one. Number two, I am cutting your capsule. Capsule is the layer which covers the joint and keeps it into position. Second, it is done through such a approach where the forces are going to act to get the hip out from that side. When is the dislocation going to occur? When I am sitting in this position, I am trying to get up. When I'm going to go into squatting, what is happening is this is my socket, this is my hip, and now I have flexed like this, and all the force is going to come on the backside of my hip where it is going to dislocate. So a posterior dislocation is most common. I have cut the capsule on the posterior side, I have cut the muscles on the posterior side, and the hip dislocates posteriorly. If I save these and go from the anterior side and allow my patients to sit cross-legged or squat, even if they do that and there is a pressure which is exerted on the capsule or the muscles on the backside of my hip, all that is intact.
It's protected.
It is protected, so
Yeah.
it will not dislocate. Number one. Number two, why will be there limb length discrepancy is because I have cut your muscles. So when I get your hip back into place, there are a few tests that we do
Acha.
that the hip is not dislocating intraoperatively when the patient is under anesthesia. So, since the constraint of the muscle is lost because I've cut the muscle, I tend to elongate it so that I make it more stiffer so it doesn't dislocate. So it is not by chance that it dislocates or it the limb length discrepancy occurs. It is by choice that I do not wish the patient to go into dislocations. I would probably not mind getting the leg a bit longer by a centimeter or so, but a stable hip is something that I'm looking for. And with the posterior approach, since the muscles are cut, there is no adequate restraint which prevents it. number one. And number two, the patient is in such a position that we compare the leg on the opposite side. And in that position, comparing the leg lengths is almost impossible. With a direct anterior approach, the patient is lying down straight, and I have the other leg immediately available for comparison. So you have a buddy who you can compare to,
Mm-hmm.
and then get the length in the correct position as compared to the other side. Plus, there are no muscles which are cut, so I cannot try and elongate your leg with your intact muscle. So, direct anterior approach prevents or gives you two things. First is the chances of dislocations have reduced dramatically even after going back to your normal routine like squatting, sitting cross-legged, or going and playing tennis, basketball, or cricket maybe.
Mm-hmm.
Yes, do I allow them to play contact sports after hip replacement? The answer is no. If someone asks me that I want to go and play rugby, kho, kabaddi, probably no. It's not something that is advisable.
Mm-hmm.
But rest of the recreation sports can be very easily done without a chance of dislocation, and you get the perfect length back in direct anterior approach.
Okay, sir. So, from your clinical experience, what kind of differences have you seen in post operative outcomes and patient satisfaction regarding dislocation rates and limb length equality using DAA?
See, 3 years, 3 months down the line, the patients are happy post hip replacements. Pain relief is the one thing that they want. So all of them get it. What is the difference with the DA? The patient walks into my OPD 7-10 days post surgery without a walker, without a stick, walking independently.
Mm-hmm.
And the OPD patients who are sitting next to them, they are surprised to know that these patients have undergone a hip replacement maybe a week's time back. So they are much more independent immediately post surgery. Their pain, the analgesics that we need to give, the painkillers that we need to give had dramatically gone down. Their walking aids have dramatically gone down. The patients show me in the OPD sitting on the floor cross legged within 10-15 days of surgery. And their satisfaction rate has skyrocketed to a very large extent post DA. That is one thing for sure.
So, if I have to ask you, what would be some common complications that we see post DAA?
No approach is without
Of
complications. So every
course,
approach has its own advantages and disadvantages.
true.
The most important complication for a DAA is a novice surgeon.
Acha.
So if you are not well versed with this approach, this is a difficult approach to do. This is something that we have not been trained in our residency, in our training to do. So now my fellows who are getting trained under me,
Mm-hmm.
they are seeing this approach probably from their beginning. So for them, for the next generation orthopedic arthroplasty surgeons, it might be easier. So the complications are nerve injuries, which are the femoral nerve, which runs very near the hip on the front side of your leg. Second is a vessel injury, and third is a femur fracture. And if you get a femur fracture with a direct anterior approach, it is a bit difficult to treat that particular complication. So in the initial phase, you have to be very very choosy about your patients. As I said, in the first 50 we were very choosy that we were not doing everyone with a direct anterior.
Hmm.
But other than these two complications, we have not encountered a single patient with dislocation. We have not encountered a single patient who is not able to sit cross-legged or squat. So every one of them can do it without fail, and none of the patients have experienced any limb length discrepancy. Their leg lengths are absolutely same.
So, what message do you have out, have for all our viewers out there who might be requiring hip replacement?
Yeah,
And, because as we spoke during the initial part of this podcast, that, hip replacement is a surgery which is, a lot of people are very apprehensive about it.
correct.
So, what message do you have for them?
See, if you are a young patient who needs a hip replacement, you have you have some approach which will give you back the normalcy, which will give you back the full life where you can squat, go and play sports and do everything. So choosing a direct anterior approach combined with robotics can give you a perfect hip back. Do not choose an implant which is going to wear out much faster for the sake of stability, for the sake of gaining moments. Choose the correct approach, not the wrong implant. So correct approach will give you back the normalcy, will give you back a normal activity levels and a pain-free hip. So anyone who needs a hip replacement should think about a direct anterior approach. Yes, there will be few patients in whom we will not be able to do direct anterior approach, but in majority of the cases, maybe 90 to
It
95%
can
of
be
them,
done.
we can do a direct anterior.
And as you said that this advancement, which is the direct anterior approach, is something which was not taught during
Correct.
your
Training
course
period.
training period. So what message do you have for all the surgeons out there who want to master this, and
Yeah, this is a
what would
good
be
technique that to learn. This is a fantastic surgery where the satisfaction ratio is phenomenal and dislocations and limb length discrepancy is almost none. So you need to master this technique. For that, you need to go and learn it under someone who is doing it. Learn it as a proctor from him. Maybe ask some of your friends who is doing it to come down at your place and show it to you for the few cases. And once you are confident enough to do it on selected patients. Choose a very thin built patient, preferably a lady, so that the muscle power is not really that hard compared to a male. And once you start mastering it after the first 50, then you can increase your difficulty levels to a bigger challenging cases. But it is an approach which needs to be learned by a majority of arthroplasty surgeons of my age or elder than me. But this approach is going to give all the patients their hip back to 100% normalcy.
so with so much of experience that you bring on the table, and you have practically seen orthopedic from that shift of that traditional approach to this advancements which are coming up. So are there anything in which is coming up in future which is you are really excited about, or you really look forward to some of the other advancements?
Yeah, there are a few implants that are coming up, whereby the way in which we fix your hip back into place. At this point of time, we need to put a longer rod into the shaft of your femur. So there are a few implants which are coming up, which are going to be comparatively much shorter.
Acha.
So what are the advantages of that? When I want to revise it after 20, 25, 30 years of your hip replacement, I still have a good bone available below the implant, so that revising it later
Mhm.
becomes much easier. There will be a lot of new advances coming up in robotics,
Mhm.
image based and image less both. There will be autonomous robots that are coming up. We already have few autonomous robots available in our country and in the foreign nations for the knee. Development for autonomous robotic systems on the hip is underway. I have seen a few cadaveric courses where I go and calibrate them. So these are the technical advances that will come. And then the last is the metallurgy, which is a changing metallurgy. And with that 3D printing concept coming into view, we can probably print a separate implant for you.
Acha.
So if I want to do a hip replacement for Dr. Tushita, I go and ask a company to print a XYZ size, only one implant which was produced only for you,
So
which
like
will go and fit
100% customized.
100% into your hip, not only the hip, the knee. And that particular technology is around the corner. Maybe next 5 years time we will see a technology where we get a implant which is designed for your specific needs. So that's the technology I'm looking for.
Lovely. That would be great. I think one of
Yeah.
the major milestones orthopedic will see. So, moving on to the next segment, I have a few lines which might be a myth or a fact, a few questions which might be, you are tired of hearing. So, let's get into that. Patients cannot walk or bear weight immediately after anterior hip replacement.
Myth.
Okay. So,
They can walk the minute their anesthesia is out.
hmm,
They can walk probably without support also if they are younger ones. So elders will need some support for walking. They can put full weight on the legs.
that sounds like a dream, I must
We
say.
operate a lot of patients for a bilateral hip replacement on the same stage, same
Acha.
day, and we make them walk the same evening.
Okay.
So if I have undergone a bilateral hip replacement, how am I going to walk without putting weight on that leg?
True.
So all the DAs walk the same day with full weight on that.
So myth, myth, and myth. Okay. Anterior approach requires very specialized centers and is rarely available.
It is available, but it requires a real special training.
Yeah, and special expertise
Yeah,
and all
you
that
need special
stuff.
expertise. You need to master that particular technique, and it's a new technique which needs to be mastered by many surgeons at this point of time.
Mhm. Patients cannot walk. Okay, this is done. Leg length discrepancies are unavoidable after hip replacement.
To some extent true, but to a large extent myth. With a direct anterior approach, you can get the leg length to back to 100% normalcy. As I said, to some extent false, is because if the patient has a bilateral disease
Mm-hmm.
and I am operating on only one leg,
Mm-hmm.
my operated leg is going to get longer because the other side is shorter. It
Correct.
is not because this side is longer. I
That's
have
right.
got the this side to its normalcy,
Mm-hmm.
and when I operate on the other side,
Mm-hmm.
the legs will be equal.
Okay. What age is considered too old for hip replacement?
None.
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 So what's the
The highest
old
age at which
eldest
we
age?
have done a hip replacement is 108 years.
108 years, and the
Yes.
youngest one?
16.
16. Okay. How long do hip implant typically last?
It depends on what material you are using. There are a lot of materials available. So the commonest material which is being used for younger age patients would last for anywhere between 20 to 30, 31 years. The follow-ups which the registry data says is the highest follow-up is 31 years.
Okay. Are there any activity restrictions post surgery?
For the conventional approaches, there are a lot of activity restrictions,
True.
but with the direct anterior approach, there will be only one activity restriction, and that is contact sports.
Not true. What's most common misconception patients have about hip replacement?
That the patients are not able to going to be able to squat or
Mhm.
sit cross-legged is the commonest misconception.
Okay. Do hip implants set off airport metal detectors?
Yeah, they do, but nowadays we give them a card or a certificate which says that your hip or the knee has an implant inside which is going to get detected by a metal detector. And majority of the persons on the airport also know that. So the minute you show them the certificate, none of
They
them are going to
understand
make any issues
issue
with
of
that.
it. What's the trickiest part of a hip replacement surgery?
The trickiest part is to get your hip into perfect position and maintain the leg length by something called as offset adjustment.
What's the biggest myth you have heard about hip replacement?
That I'm not able to walk after a hip replacement.
Okay, so that's about that. So before we let you go, we would like to hear some interesting, challenging case from you, which I know you will have a lot of them. But one story, we have to hear it out from you.
This is something that has happened in the month of April, May this year, 2025, where we got a patient from Tanzania.
Mm-hmm.
The patient had, well, he was a 74-year-old gentleman with a lot of cardiac problems, ischemic heart disease with very low ejection fraction. He had undergone multiple surgeries for his knee in the past, and the last surgery was done around 8 years back. He also had undergone a hip replacement on the right side. On the left side, he sustained a hip fracture, which was treated non operatively in his country because he was very high risk for any surgeries.
Mm-hmm.
When he came to us, we found out that he has undergone a surgery called as a tumor implant for his knee, where
Acha.
half of his thigh bone was taken out, and the rod which was put into the rest of the femur had destroyed the whole of the femur. So, for all practical purposes, there was no femur or thigh bone available where I can probably fix or replace his hip. So, that was one challenging case where we had to do a complete femur replacement. That means from the knee to the hip, the whole of the leg was replaced with metal,
Mm-hmm.
with a special type of a implant on the knee and a special type of a implant on the hip.
Hip.
And it's now nearing 8 months from surgery, and the patient is walking independently with, yes, he uses a shoe raise because his previous surgery had left him shortened by around 8 centimeters. So we could get him the length back to that level, and now he walks very well. This is not a surgery to be done in the young. He is a
Mm-hmm.
74-year-old gentleman where his mobility is going to be restricted to household ambulation.
Mm-hmm.
But without this, he would probably been in bed.
Mm-hmm.
So this was something in my life the most challenging surgery I have ever done.
So you throughout your entire career as an orthopedician, what's that one thing you have learned, and what is that one thing which is your mantra, go to mantra?
No two patients are same. So even if you are doing 5 knee replacements a day, every next patient is a new challenge. So don't be complacent. Every patient, for him, it is the first surgery and he wants it to be the last. So every patient you have to give your 100% to give him back the normalcy.
And what do you do to keep yourself so calm and composed and sorted all the time? I've never seen you angry or
So
you are always in the same
in the
plateau.
theater, have your backups ready. So if something goes wrong, you always have a backup ready available. And if you have calculated everything, then you are going to be at peace.
That's wonderful to know. So before we wind up today's podcast, any last message that you want to give out to all our viewers?
So all those who have a hip problem and have been advised hip replacement surgery, do think about a direct anterior approach surgery and robotics added to that. It is a fantastic approach that has been now done everywhere in the world, particularly in our country where our people want to go back onto the floor, sit down, cross legs, squat, maybe participate in their family functions, dance a bit, or go to garba and dance there. So this particular surgery is going to give you back a complete normalcy in life, except as I said, contact sports. You will be able to drive, you will be able to sit cross leg, do and go puja every day, or for our other friends, where you can go and do some climbing, mountaineering. So if you are suffering from hip arthritis, if you have hip issues and been advised the hip replacement, definitely think about a direct anterior approach.
On that note, do make sure that you talk to your orthopedician about the direct anterior approach. And on that note, signing off. Thank you so much, sir,
Thank
for
you.
coming to Sahyadri Health Talks. Dr. Tushita signing off, Sahyadri Health Talks.